Well, good afternoon, everyone. We'll just check that everyone is actually in the room now. Yep. So good afternoon, good evening, everyone, and good morning as well for Hamid, and we're spanning the globe. So we're very fortunate today to have Dr. Hamid Kazerouni, who is a faculty member at McMaster Hospital in Hamilton, Ontario. He is the Deputy Chief Medical Officer at Diagnexia, and Diagnexia are very generously supporting this program. He's very busy, so we're very with consults and with help running Diagnexia for everyone. So we're very fortunate to have his time. He's got a long, distinguished career in gynecological pathology, and has also been awarded several awards recognizing his teaching. He's taught medical students at Oxford University Medical School. He's a noted author. He's also got publications on lung cancer and neuroendocrine carcinoma as well. He was awarded the John Fernandez Teaching Award from McMaster University, and he maintains a faculty position there. Now he's concentrating on Diagnexia, and I think that should be sufficient, I hope, to outline how fortunate we are to have Dr. Kazerouni today. We may just give another minute before we start. Actually, we've probably got enough participants to get going. So without further ado, I'll pass over to yourself, Hamid. Thank you.
Thank you very much, Richard, for a kind introduction. And good morning, good afternoon, good evening for your attendance. I know you're in different places, and my time is almost 9 o'clock in Ontario, Canada. And we have beautiful, beautiful fall. The color is, I can't describe it. I'm sure in wherever you are, you have, different type of beauty. And thank you very much for attending. And I decided to just give an update. It's not really an update anymore because it's almost, 5 years, which we have the last WHO book, which regarding, an update on endocervical adenocarcinoma and the Silva classification. And those of you who practice gynaecology, and I don't know, obviously, how many of you really use Silva classification? But even if you don't, I just want to go through it, and it's part of WHO now. It's recommended to be used. So let's just go through what we're going to talk today. It's, I'm going to just go through this one, and hopefully if we have some time at the end, we can have some, question. And if we don't have time, then, I would be happy if you have any question, you can just email me. If I can, then I will answer those questions. So it's going to be just a review of 2020. It's 5 years, and we don't know when it's going to come the next one, but it's still relevant, of the classification of cervical adenocarcinoma. We are talking specifically about adenocarcinoma of cervix. We are not talking about squamous entities. And then review morphological criteria for the endocervical adenocarcinoma in situ. And you can see the relevance of reviewing this part, and then delineating the criteria for pattern-based classification of endocervical adenocarcinoma, which is Silva pattern. So in group of experts actually look at so many cases of cervical adenocarcinoma. They wanted to know if they can find, rather than just looking at morphology, and because prior to that one, we were just using morphology for making the diagnosis and subtyping those adenocarcinoma. But then they, get together and they look at so many cases of adenocarcinoma, and they wanted to know what is the, pathogenic of these carcinoma. They did H&E of adenocarcinoma and adenocarcinoma in situ. And they did look at the P16 as a surrogate marker, and they did in situ hybridization for high-risk HPV virus test. And P16 was a surrogate for high-risk HPV as well. So they look at those cases and they could see if they can see what subtype, the morphology can be associated with HPV and what they cannot be. And then they did publish their finding and they proposed a classification in 2018. What they did, they look at under, for the adenocarcinoma in situ. As a resident, as a practicing pathologist, when you want to just look under the microscope for a cervical tissue, either biopsy or lips, whatever comes under your desk, and under low magnification, if, scanning magnification, if you can easily see apical mitosis and some apoptosis body, choriorhexis at the base mostly. If you see that one, that is most associated with HPV, which we call it HPV associate or HPV-A. And those cases which they couldn't really see P16 positivity or there was no in situ hybridization positivity for high-risk HPV, they was really very difficult to see any of these, or they were completely absent of this apical mitosis or apoptosis. Then they were classified as HPV independent. Okay, on the picture which you can see here on the left side, in the low magnification, easily you can see through I hope you can see my mouse. Do you see this apical mitosis? Another one here, 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 and then some apoptosis at the base. And whereas on the right side of the this picture, you can see there is really almost there is no mitosis which is identifiable. Okay, and so the left side would be a HPV associated, and the right side would be HPV independent. So prior to 2018, in fact, 2014 WHO, as I said, was really classifying this tumor based on purely morphology. Okay, and then after 2018, WHO 2 years later adopted this proposed by endocervical adenocarcinoma classification, which IECC group. And so as you can see on right side, HPV associated endocervical carcinoma was classified again to usual type, which majority of the cases are, and then I will show you some of those cases, how they look like, and then mucinous type. Again, mucinous was divided into different subtype, NOS, intestinal signet ring cell, and other type, and then HPV independent endocervical adenocarcinoma, which was, again, there was no HPV positive, P16 positivity, and in situ hybridization was negative, and these were classified as gastric subtype, clear cell type, mesonephric, endometrioid, and others. So in 2020, again, precursor glandular lesion in situ hybridization, in situ adenocarcinoma AIS was, you divided into HPV associated usual type and SMILE. Okay, SMILE stands for squamous, in fact, stratified mucin producing intraepithelial lesion, and independent, which I mentioned it before. So, for the resident mostly, when you look at any cervical tissue, the first thing you want to really know, is it abnormal, is it normal or abnormal? This is almost normal cervical tissue from a resection. And you can see, there is almost the density of these glands are relatively normal. For those of you practice gynae or you practice pathology, you can see this is not abnormal density of the gland. And then when you go to higher power of these glands, you can see these are lined by tall columnar with lots of intracytoplasmic mucin and the basally located nuclei, and there is no mitosis, not nuclear atypia, and no apoptosis body. These are the normal looking cervical glands. And when you look at this one, obviously what you can see in an area like this one, which is kind of normal looking endocervical glands. Whereas here, here in low magnification, what you see the nuclei obviously became dark. They became more, pseudo-stratified. And you can see here, for example, there's an abrupt transition from normal to abnormal. Again, higher magnification. When you look at here, you can easily see that and this nuclei are dark, hyperchromatic. They are pseudo-stratified, right? And you can see abrupt transition from normal to abnormal. Okay. When you see this one, based on what I told you, it's really, you are dealing most likely with a HPV-associated adenocarcinoma in situ. It's not invasive. I hope you can appreciate, because the density is not really as much. And there is no stromal invasion, and then I will talk, later about the criteria for invasion. This is a higher magnification. On the left-hand side, you can see the full thickness of this epithelium is abnormal, which I'm not going to talk about squamous epithelial lesion. But on the right side, you can see at the transformation zone, in fact, you have this glandular lining, which they are darker, they are enlarged, and there is stratification, pseudostratification, and some mitosis. Again, another one, easily you can see there are apoptosis all over the place. These are choriorectic debris. And then you can see some mitosis, and the nuclei are dark, elongated, pseudostratified. This is based on, low magnification. You can say this is HPV-associated adenocarcinoma in situ. What about this case? So what you can see here, obviously, again, it's definitely glandular. There are some normal glandular element, and then you get abnormal one, which again, apical mitosis, apoptotic bodies, and then hyperchromasia, all of those, and then became more complex. What do you think? Do you think this is now carcinoma, invasive carcinoma, or is it the adenocarcinoma in situ? So we will talk about those, how we make that distinction. What about this one? We have intraglandular proliferation in the form of papillae, or sometimes you may get, like a cribriforming, like here, okay? Those abnormal gland, again, hyperchromatic, lots of mitosis, apical mitosis, and then normal looking gland, endocervical gland, and these are abnormal, okay? So if you go back, this complexity, so we are thinking about, okay, we know this is a HPV-associated adenocarcinoma. The question is it still in situ or is it invasive, right? So when we look at this picture, you can see, obviously, there are these glands. This is normal looking glands, and these glands are abnormal because you can see there are some nuclear hyperchromasia, enlargement, and some apical mitosis. What you notice, you have this intestinal metaplasia in the form of goblet cell metaplasia. So when you see goblet cell metaplasia in the cervical tissue, or either resection or a biopsy, by itself, it doesn't really make a diagnosis of adenocarcinoma in situ. At least it doesn't. So, but it has to alert you and warn you that you may have adenocarcinoma in situ, at least somewhere within your specimen. Okay. What about this one? This is what I was talking about, your usual type adenocarcinoma in situ, and another type, which is SMILE, or stratified mucin-producing adenocarcinoma, mucin-producing intraepithelial lesion. What you see from the base to the top, these are mucin-containing glands. All of these cells has got mucin, and then you have lots of mitosis and nuclear atypia. And if you do, P16, it would be a block positive from bottom to the top. Or if you do in situ hybridization, it would going to be positive for high-risk HPV. So this is a type of adenocarcinoma in situ, in fact. And it is HPV associated. What about this one? So we have glands in endometrium. We have obviously dark nuclei. We have pseudostratified nuclei. There are some, mitosis present in places. So when you see this one, so do you think this is obviously based on what I told you, this is adenocarcinoma in situ. But what you have to be careful, what could mimic that one, right? What if you look at in the background, what you see is a kind of endometrial stroma, what you have. So in fact, this is a tubular metaplasia or tuboendometrial metaplasia, or endometriosis in the background. Okay, that's a mimic you have to just be careful about. And you can do P16. Usually these are not P16 block positive. So either tubular metaplasia, or you may have endometriosis in the cervix, which can mimic, in fact, the adenocarcinoma in situ. And this is another case of tubular metaplasia, you can see here. And again, if you just don't pay attention and you think, okay, there is, pseudostratified, there are dark nuclei, and then, obviously you may have even occasional mitosis, then you may just, calling it adenocarcinoma in situ at least. In fact, this was a post biopsy of another, it was a lip biopsy from someone who has multiple biopsy prior to that one, and that was the cause for tubular metaplasia. I'm sure you have seen, P16. When we say P16 positive or negative, I don't like that terminology because it doesn't say exactly what we mean. So if you have this, positivity here, is it really P16 positive test or not? When we say, we usually use in our report, block positive, meaning then we are implying that what we have is definitely a surrogate for high-risk HPV. If you have just patchy positivity, like you have here positive and then some negativity, which we call it patchy, this is not a positive test. So it's better to use really on your report is block positive or negative. You can say patchy positive. So what about this one? Based on what we have already talked about, obviously we have cervix with all these abnormal, glands. The density is slightly higher than what you expect, but again, do you think this is invasive? This is in situ? That's the question, of course. And so you can see these glands are, abnormal because the nuclei are pseudostratified, they are dark, and believe me, there are some apical mitosis, there are apoptosis. And the question is it just in situ or invasive? You can see, and this is, another higher magnification of the same case. You can see all the features which I described, apical mitosis, apoptosis in the background and in the basal area, and hyperchromasia. So again, intraglandular proliferation, is it invasive or is it still in situ? What about this one? Complexity is higher, right? So what I'm trying to say, okay, what is the management of invasive adenocarcinoma? The management still is based on FIGO and AJCC staging system. And they use the tumor size and depth of invasion, okay? And those of you practice, how difficult it is. And, sometimes really even amongst the pathologists, it's not really consensus, how to measure exactly. And, when it comes to practice, it's not as easy as even, we describe or we read in any given book. And we know that, difficulty in diagnosing the presence of in early stage diagnosis is very difficult. And when you look at, for example, phygostation 1A is something when you don't really see any grossly any, tumor, but you diagnose that one under microscope, is 1A1 when it is, 3 millimeter or less, and when it is more than 3 millimeter, but not more than 5 millimeter, 1A2. But B is obviously above this 1A2. So why is important this one? Because if you make the diagnosis and make the measurement, and if it is 1A2 above, then you may get, in fact, a lymphadenectomy. And lymphadenectomy, in fact, let me show you what you may end up with. So in fact, if you have a lymphadenectomy from a patient who has got adenocarcinoma, let's say you make the depth of invasion into the criteria which they do, lymphadenectomy, then you may get, a huge complication. So the question is, are there any pathological parameters that better identify patient at risk of developing lymph node metastasis? Because if we can distinguish the cases which really they may have very little or no risk of developing lymph node metastasis, we may prevent this complication. So then it comes the pattern-based classification, which is the Silva system. I don't know how many of you guys include the Silva pattern in your report. And I know in Canada, we have started, but not every center they use. But that is part of WHO again, that is included in WHO in 2020. So what, this is Dr. Silva from MD Anderson, and he and his colleagues, they look at 350 cases of endocervical adenocarcinoma, HPV associated only, okay? So we are not looking at any HPV independent cases in the Silva pattern. And they have come up with 3 patterns, A, B, C, and the distinct pattern of invasion and with a different clinical behavior. So usually when we use the criteria for invasion, we look for the presence of single or incomplete glandular gland into the stroma, stromal desmoplasia, presence of lymphovascular invasion, loss of normal lobular configuration, presence of malignant gland beyond the limit of normal gland. When we say that one, how difficult it is, really. It's very subjective. Where is the beyond? And it's not really well-defined, border. And then gland adjacent to the thick-walled blood vessel. Again, you may have really cases which there are some gland next to this thick-walled blood vessel. It doesn't really look like malignant. It doesn't behave like a malignant one. So in Silva classification parameter, what they look at the tumor stromal interface, which I'm going to just show you, presence or absence of distractive stromal invasion, presence or absence of lymphovascular invasion, architecture and grade of cytological atypia. On this cartoonish on the left side, you can see on the top is a pattern A Silva pattern. The most important is there is no distractive stromal invasion. Look at here. You can see there are usually the lobular architecture is preserved. There is a lobular here, here. So there is no really, obvious stromal invasion, which is destructive, okay? And then well-demarcated rounded glands. You can see it's very, you can draw a nice line around this gland. They may have some complex intraglandular, growth like papillary or some cribriform, but there is no any, invasion into the stroma, and there is no desmoplastic reaction. And then when you look at the lymph node, the lymphovascular spaces, there is no lymphovascular invasion into any of these, okay? And pattern B is an early or limited destructive stromal invasion. You may get the same as pattern A, but what you get some cells invading into the stroma and causing some inflammation or stromal reaction. And that field shouldn't be more than 5 millimeter in diameter, or if you look at on the microscope, shouldn't be, filling the ×4 on your microscope field. And if you look at here, for example, on the histology section, you can see there are some glands which are abnormal, and then there are some cells which obviously, getting off the these well-defined glands into the stroma, causing some stromal reaction and inflammation around them. You have to go to high power to see them, which I will show you later. Whereas on type A, you can see there is this lobular configuration has been retained. There is no obvious stromal reaction. There's not much of inflammation, which you can go into higher power and examine. And on the pattern C is the most, obvious one, which you will see in any given invasive adenocarcinoma. Is an extensive and diffuse destructive invasion and desmoplastic reaction, and the glands are angulated. They may have single cell, and you can see it. There is this extensive stromal invasion. You may have lymphovascular invasion, obviously. So what's the importance of this pattern A, B, and C? So when they look at their, the cases, they have seen in pattern A group, there was almost no lymph node metastasis. So in fact, they were invasive adenocarcinoma based on their, pattern of invasion, but there was no lymph node metastasis. Therefore, and there was no recurrences, and there was no, death of the disease. No one died of the disease. So therefore, in this category, pattern A, they realized really you don't need to do lymphadenectomy. Therefore, you can prevent the complication, either doing sentinel lymph node or, a lymph excision of the lymph node over there. You really can prevent that complication. And then pattern B, they have seen they were lymph node metastasis increased to 4.4, and there was one recurrence which was happening in the vagina, and there was no one died of the disease. Whereas in pattern C, which is obviously expected, it's it's an obvious invasive adenocarcinoma. The lymph node metastasis was 23%, 22 almost recurred, and 8.8 or 8.9, died of the disease. So no going back again to our slide. So when you look at this one, do you think now for resident, is it really adenocarcinoma in situ? Because then I'm sure when you look at it on the microscope, always this dilemma comes, is it invasive or is not, right? And there is really observer variability amongst even the expert and the gynae pathologists, which they look at the gynae cases every day. So when you look at here, you can see the lobular configuration is retained. It is obviously more dense glandular population here as opposed to normal, okay? But the lobular configuration is reserved, and you can see these glands are round. There's no really drop of any cell, single cell into the stroma. There is no stromal reaction, and there is no lymphovascular invasion anywhere in this specimen. Therefore, it is considered as pattern A. And then obviously you have to measure this one, because as I told you, the management of the cases of cervical adenocarcinoma are based on AJCC and in fact, FIGO. And if the measurement, which you know, is going to be not easy. Usually, there is, where do you measure the tumor? I will show you some cases which can be really, really difficult, and there would be no consensus. Again, this intraglandular, complexity, again, this is really invasive or is not. This one, which I showed you before. What about this one? Look at that one. Do you think is pattern A, pattern B, or pattern C? I don't think so. You would say this is pattern C, but what about pattern A or B? Just I'll give you in a few seconds. Just look at that. So if I can convince you again, there is definitely a vague lobular growth pattern here. I do not really see, there is some, inflammation and reactive inflammatory cell here, but believe me, there is no stromal invasion here. So still this was a pattern A, even though it looks very crowded. And if you want to measure this one, definitely it's gonna, it would be more than 3 millimeter, meaning it would be 1A2, and 1A2, it can really get to a lymphadenectomy, for the management and complication, which we can come with. So what about this one? You can see there are in here, some of these glands, maybe there is dark nuclear, and stratification perhaps. And then here, okay, what do you call this one? Is it adenocarcinoma in situ? Is it invasive adenocarcinoma? If it is invasive adenocarcinoma, where do you measure it then? Obviously, you're gonna measure it from here to here. It's overkill, definitely. But there is no other way, okay? That's what you can see. Some patient, maybe in one center they call it, less than 3 millimeters. Some center call it 4 millimeters. Depends who, make the measurement. So whereas pattern B, pattern A, if you call this one, let's say pattern A, Silva pattern A, then really doesn't matter really that much measurement in that case, right? So again, this is more cartoonic of the pattern A. You can see, there is pattern A type here, perhaps here, but you can see there are some single cell or angulated cell invading into the stroma, but it's very limited. And there is no any solid growth pattern. Because if you have solid growth pattern, you pass the pattern B. Look at this one, for example. Again, you have a cervical tissue, you have normalish in the right side, and then you have an area which is definitely crowded. There are some, pseudostratification, dark nuclei, typical mitosis and apoptosis. So you are dealing with at least adenocarcinoma in situ / pattern A or pattern B, right? So when you go, you can see here, there are something funny going on, like here, single cell, small group of cell just get off the main glands, and there is stromal reaction. And when you go to high power, you can see these single cell with the stromal reaction and some inflammatory reaction. So when you have this one, then where do you go from pattern B? This is at least pattern B. From pattern B to pattern C, you have to measure it. If it is, is not filling a ×4 or not more than 5 millimeter in linear, and then this is pattern still B. And if it's bigger than 5 millimeter, you are just passing to pattern C. Another case, you can see here, pattern A, pattern A, pattern A, and then, this area has got stromal reaction with some single cell and small angulated incomplete gland, which cause at least pattern B. And it is less than 5 millimeter. Higher magnification. If you need to do some cytokeratin staining, sometimes may be needed just to make sure these are epithelial. And Path C, as we discussed, it was definitely very obviously, you can see kind of very extensive stromal reaction to your angulated, ugly looking or very solid invasion. This is, when you look at this one, is it pattern A, B, or C? I'm sure majority of you would say this is pattern C because these glands are invading extensively and there is stromal reaction definitely all over the place. And then obviously you can see it's more than 5 millimeters. This is again, those glands, extensive stromal reaction all over the place with angulated, some single cell all over the place. What about this one? We talk about, obviously thick blood vessels. I have seen cases which are pattern A, and you get it to, next to the thick blood vessel. Or sometimes you get some adenocarcinoma in situ close to these. So really that doesn't really much help. Yes, I know we use it and we have used it in the past, but I'm not really relying on that one. But what I rely is on the stromal reaction to these angulated or single cell with the reaction to the malignant glands. What about this one? So we are still talking about endocervical adenocarcinoma, in fact, HPV associated. This is one subtype of usual type adenocarcinoma associated with HPV, which is viloglandular subtype. So sometimes you get a malignant, cervix, which comes under your desk. And then you look at under microscope, you see all is exophytic coming to the cervical, canal. And there is either no invasion or very limited invasion. So the question is, if you measure it from where do you measure the thickness or the depth of invasion? Because as I told you, again, if it's changing the staging, then you may end up with a, unnecessary treatment for the patient, which comes with it some, implication. So this is a viloglandular subtype. What you get this, villous growth pattern with lined by this single, columnar cell, and sometimes the nuclei are not really as bad as usually are in usual type adenocarcinoma of cervix. And you may get, majority of them, they may not have any invasion into the stroma or get really a superficial invasion into the stroma. Then you have to, for the measurement still we will give them as, from the top to the bottom and give a comment and talk about, okay, this is exophytic, blah, blah, blah. And then we say the stromal invasion, we will give the stromal invasion as well as the depth and as well as the thickness. But the bottom line is, if there is no invasion into the stroma, we call this one pattern A, regardless of the size. And you can imagine pattern A is associated with good prognosis and has, almost no recurrences based on their study. And there is a chance of lymph node metastasis very low. We don't have to do sentinel lymph node or resection. And if there is stromal invasion, again, could be pattern B, but still the chance of lymph node metastasis is very low. This is another example of viloglandular. This one, you get with usual type hyperplasia, you may get this pattern of invasion, which is macropapillary pattern, the same as like in breast, or you can get it in, bladder, in urothelial type. So these are the same, these empty spaces around. So this is subtype, and you can see here another case. We talk about adenocarcinoma of cervix usual type, and we said, there are other of HPV associated which are mucinous. the mucinous divided into NOS, intestinal signet ring cell, or invasive stratified mucin carcinoma. When do you call it usual type? When do you call it mucinous? So when you have more than 50%, because in usual type, you can get intracytoplasmic mucin, but this is from 0 to 50%. If you have more than 50% of your tumor cells has got intracytoplasmic mucin, then you call it, in fact, mucinous. If it is more than 50% of tumor cells has got intestinal metaplasia, then you call it intestinal subtype. The same, more than 50%, if it's signet ring cell, you call it signet ring cell. For the invasive stratified mucinous carcinoma, if you remember, I talked about SMILE, that is a in situ entity, in fact, but this is invasive. What it looks like, it's like, in higher magnification, you have a tumor, you have palisading, and then the cells, this nested cell has got intracytoplasmic mucin. These usually behave in an aggressive way. Just, make sure you make that. If you do HPV, they are HPV associated. Therefore, P16 would be blood positive. And if you have to do in situ hybridization, those come back positive. So we talk about HPV associated, and then we go to HPV independent. These are not as common, obviously, as HPV associated, but they are important to know about them and make the diagnosis. So there is a spectrum of cervical gastric type lesion, which, you can just have a mental exercise next time you're looking at some of your, resection specimen for leiomyoma, whatever, you may end up seeing some of these. Started with a pyloric gland metaplasia is not uncommon. If you pay attention, you will see those. I'm sure you have seen type A tunnel clusters, which you don't pay attention because they are not really significant at all. You may get lobular endocervical glandular hyperplasia, but when you get atypical lobular endocervical glandular hyperplasia, which they interchangeably use it as gastric type adenocarcinoma in situ, these are relatively newly recognized entity as a precursor for gastric type adenocarcinoma of cervix. This is, a pyloric type metaplasia. You may see it on cervix, in any curettage or any biopsy or dissection. Again, tunnel A, type A tunnel clusters. What about this one? When you look at these groups of cells, if you pay attention next time when you have a section, if you have this one, so you can see they look slightly different than what we see in cervix. They have tall, sometimes they are cuboidal, but these are definitely tall columnar. You have a distinct cell border. The cytoplasm are pink to pale fluffy. That is what the description is. And you may get really a nice basally located nuclei with the mild atypia, or the atypia can be slightly more, like moderate or sometimes severe. And if you go, this is another case, but if you may get apical mitosis, not common, but you may see, and nuclear atypia, enlarged and prominent nucleoli. So when you have these, you see how distinct cell border is, the quality of the cytoplasm. This one, again, definitely you have cell border, very distinct, very pink cytoplasm, and the nuclear atypia. This one as well. These are all considered as a precursor or gastric type adenocarcinoma in situ. If I have to be honest, I cannot recall last time I make that diagnosis, on its own. When I had a case of gastric type adenocarcinoma, then I look very carefully, I can convince myself yes, this probably it is a in situ component. So I did talk about this gastric type, morphology criteria, which are again, no HPV associated like feature, which I talk about. Mostly you don't see, but you may see some apical mitosis, and they may have a variable morphology. And what about this one? When you look at this one, you say, okay, it looks like benign endocervical gland, next case, right? I'm sure some of you have seen these cases, and these are the cases which are, this is in fact an invasive gastric type adenocarcinoma at one end of spectrum, a well-differentiated or minimally deviation, in the past we would call it, right? This is what you can see. There was, all over the place, these well-differentiated glands. And if you carefully look for, some of the glands, you may see some of them have nuclear atypia, but majority of the glands, they are basally located nuclei, well differentiated. It's hard really to convince yourself this is malignancy. The other side of the spectrum, what you may see, in fact, is, more moderately to poorly differentiated gastric type. Again, if you look at the cervix and you see something like this, I'm sure you say, okay, what is it? It doesn't really look like a usual type HPV-associated adenocarcinoma. What you see here, again, well-defined cell border. You can see the cytoplasm is fluffy, pink, right? You can see how fluffy it is. And then you will think you have to have, a suspicious mind for this and knowing the entity. But these are the features, because immuno is not going to be hugely helpful. Yes, you do HPV, majority of those cases, HPV would be negative, P16 negative, or you send for in situ hybridization, come back negative. But it will come back to really morphology. CK7 are positive, ER/PR very rarely can be positive. P16, as I said, mostly negative, can rarely be positive, but even if it is positive, you send for in situ hybridization, it will come back as no high-risk HPV. And then, PAX8 can be almost to 70% positive. The next case of HPV independent or not associated is clear cell carcinoma. This clear cell carcinoma, it's not common at all. In the past were more because of the exposure to the DES, and but these days we don't really see many of them. If I see a clear cell carcinoma which looks like clear cell carcinoma anywhere else, like in endometrium or ovary, which you can see morphologically, they can be solid, papillary, or tubulocystic architecture, and look at the cytology, they are polygonal cell and highly atypical but uniform nuclei. And when you look at the cytoplasm, again, can looks like clear cell anywhere else. So obviously it's not very common. When I see, the first thing I would think, could this be a clear cell carcinoma from the endometrium which has extended to the cervix? Okay, that's the first thing. But if you don't have it over there, then obviously you can make the diagnosis of clear cell adenocarcinoma of cervix, but are independent for HPV. They are not associated. What about the endometrioid type? Endometrioid type, in fact, they are very rare. Again, the first thing, if you see something looks like endometrioid, because you can see if you look at this one, because it's mucin depleted, kind of adenocarcinoma of cervix can look like this one, okay? But the mucin depleted usual type adenocarcinoma of cervix, which is associated with HPV, they are P16 positive, okay, which you will definitely think about that one. And P16 comes back negative, and I'm sure, if you do in situ hybridization, that will be negative too. And then, obviously, you may have, if there is a history of cervical endometriosis, then that could be a precursor for these lesions. And they are, as I said, these are HPV negative, and they may have confirmatory endometrioid feature like, squamous differentiation, and etc. And, this is the picture below is the P16, which was, definitely negative. And again, if you want to make the diagnosis of endometrioid subtype, before you make that one, you will think about could be a endometrial endometrioid extending down into the cervix before you make this diagnosis, as they are very rare. And again, for in situ adenocarcinoma of endometrioid subtype, this is relatively recently described as well. Again, I really, I never made that diagnosis on its own, and always was, after the diagnosing of endometrioid subtype of cervical site, you look really carefully, you may convince yourself there are some in situ component. Again, it looks like a typical hyperplasia gland or EIN. You can see, the nuclei are atypical, blah, blah, blah. What about this one? This is, again, a case you may end, on your desk, and you look at this one, obviously looks malignant. It's very busy. And what growth pattern do you see here? If I can convince you, there are some papillary, some glandular, there are definitely some, glomeruloid type of growth in places, and tons of mitosis. You may get tumor cell necrosis. What do you think? This is a real life. You get these cases and you have to make that. Do you think this is a usual type endometrial adenocarcinoma? Let's say this is cervical cancer. It's not coming from anywhere else. It's a usual type.
Someone suggested mesonephric.
Sorry?
Someone has suggested mesonephric in the chat.
Absolutely. So you have, why is important? In fact, the other feature, absolutely correct. Yes. What you see here, these are, if I tell you this is from thyroid, you'll say, oh, I have nuclear papillary feature of thyroid, right? You have open chromatin, overlapping grooves, all of those features. Absolutely. This is a mesonephric. So with mesonephric, what type of immunohistochemistry would be confirming that one? You may get this one in endometrium as well as cervix. So they almost have the same immunoprofile. You do GADO3 would be positive. You do CD10 would be positive. TTF1 can be positive. The most important is, because if it is, let's say, endometrial, this would be expected to be ER-PR positive, but these cases are ER-PR negative. And PAX8, these cases will be positive. So be careful about this one, because especially in endometrium, if you get this kind of tumor, which is mesonephric, these are by definition, they are high grade, very aggressive. Whereas you may tempt it in endometrium to call them FIGO grade 1 endometrial carcinoma, right? Whereas the behavior is very aggressive. You don't want to miss them. Okay, at the end, when you are reporting the cases of endocervical, cases, you want to make sure, based on latest WHO, you're going to use HPV. Is it HPV associated or HPV independent adenocarcinoma, either in situ or invasive carcinoma? You want to enter, I'm not sure if your practice is still using Silva pattern, is recommended. You can talk to your clinician. But as I discussed, it would be really very helpful if they want to make a decision, should they go for sentinel lymph node or lymphadenectomy or not. So You want to use, pattern A, B, C, as we described, and then tumor size, thickness, depth of invasion, horizontal extent. That's a controversial. Some places still they want it, but it's not really used for staging anymore. You want to make sure you mention about the present or absent of lymphovascular invasion and the status of the margin. Is it either for in situ or invasive? Is it at the margin? It's clear, blah, blah, blah. So at the end, this is 2018, the IECC, they have published their data, and WHO, adopted that one in 2022 and still is valid. We are using it. And silver classification was incorporated in 2022. Both, the IECC, this new classification, and silver, in majority of cases can be assessed. What we are talking about, you remember, for silver is only HPV associated. Those gastric and all of those non-associated, we are not going to use silver pattern. And both can help management decision, as I discussed. And at the end, if you have any question, I don't know how much time we have, or almost very little. If any question, I would be happy to.
Yeah, we've got a few questions. Thank you very much for that really good run through. I think it's really helpful presenting all the silver patterns in detail. Otherwise, as you say, it's just so complex to try and make the measurements clinically and such an error rate possible. So we've got quite a few questions. There's 3 from Dr. Prabha. Do you report the percentage of each pattern, silver pattern, or the highest pattern?
Not really. I mean, it's all depends on your local practice and your clinician, how much they want to. We don't, it's, we just, the most important, is it really pattern A, which for them is kind of reassuring. Perhaps they don't really have to go and do lymphadenectomy or sentinel lymph node. And if it is pattern C, obviously it's very, it's very clear what they have to do. It's going to go to pattern B. And pattern B, sometimes in the meeting in NDT, they may ask, okay, how much do we have? As I said, for pattern B, we should not have more than 5 millimeter. And 5 millimeter in length. So obviously it's a very limited invasion into the stroma. But otherwise, no, we don't use the proportion.
Okay. So is the silver pattern applicable to all types of HPV associated, or only for usual type?
It's, in fact, this is because majority of the silver pattern was used in the HPV associated and usual type. But again, like mucinous one, we really, it's hard to, I cannot say I have reported silver on mucinous. They are not very common, but when you see them, I haven't.
Okay.
So would be mostly in usual type.
And how do you differentiate reactive hyperplasia from a well-differentiated HPV-independent neoplasm? Can P16 be positive in a reactive hyperplasia?
Sorry, can you read the question again?
Yeah, so how do you differentiate reactive hyperplasia from a well-differentiated HPV-independent neoplasm? And can P16 help?
In fact, reactive, if we're talking about the glandular, we are talking about glandular cervical. So if it is reactive, P16 is a surrogate marker for high-risk HPV. If it's block positive, I don't really use any ancillary test unless I have good morphology. Because if it comes back, let's say P16 is block positive, it may not really be completely assuring that to calling it a, adenocarcinoma in situ. In those cases, if I still feel I'm not comfortable, I may send it for in situ hybridization for testing directly for the high risk HPV.
Okay.
I don't know if I answered that question, but otherwise, yeah.
Thank you. Can mesonephric hyperplasia be P16 positive?
P16?
Yeah. In mesonephric
Very
hyperplasia.
rarely can be positive. Again,
Okay.
nothing is 100%, but are they associated with HPV? Very unlikely.
Okay.
In those cases, in any tumor, if we have, let's say in the cervix, we have a tumor, which we are not sure really this is HPV associated and P16 positive. Definitely, I have very low threshold. I will send it for in situ hybridization to make sure this is high risk HPV associated. Yeah.
Yeah. And what can indicate malignancy in minimal deviation gastric type adenocarcinoma?
We don't use that minimally in
No.
deviation, anymore. But
Okay.
again, you have to look really for, it goes from spectrum of well differentiated to moderately or poorly differentiated group. And you have to be very, highly suspicious if you see something which looks, haphazardly infiltrating into the stroma, deep into the stroma of your cervix, and then go to high power, look for many glands to see if you can find an area which has got nuclear atypia. And again, it's really low power, and then hunt for those areas which can confirm that one. Yeah.
Okay. And just one final question. In cases where you can't do immunohistochemistry, can you still use the silver classification? Yeah,
Silver
I thought
classification?
so. Yeah.
Silver,
Yeah.
definitely. We don't really need immunohistochemistry
Yeah.
for
So it's really
silver.
useful.
And I can tell you, really, majority of our cases, we don't need immunohistochemistry to say this is HPV associated. Yes, we have the luxury of doing HPV, P16 and in situ hybridization in our center. But for confirmation, the practice here, they do it. Okay, first time diagnosis, they do it for documentation. Whereas you really don't need that one. As I said, in low power, if you see there is apical mitosis, apoptosis body, pseudostratified, and then hyperchromasia in endocervical glands, that is, highly, I'm talking about, majority of these cases, we are talking about HPV associated. I don't think so you would miss anything in that case.
Okay.
Yeah.
Well, thank you very much. We've had some very grateful comments from the audience. I think you attracted a very large audience there. Hamid, thank you for an excellent
No,
talk.
my pleasure. It's still odd if we do it from our, it's great to be able to do it from Canada to the rest, wherever we go,
Yeah.
right?
And I do the same each alternate week. So I also speak into the ether on Hempath every second week. So I know what it's like.
I know,
It's
I
like being on
know.
the radio, but we're really generating with Diagnexia's help in particular now, quite a large group each week. So thank you very much
No, absolutely.
for
The
maintaining
last
the
point I would
quality.
just say is, try to use this, what I say in low power.
Yeah.
Make that diagnosis. You don't need the immunohistochemistry, really, most of the cases. And then really try to talk to your clinician for silver pattern and educate them, if they are not aware, educate them, right?
Yeah.
And then perhaps that would be very helpful. And it would be less hectic for you as well, because sometimes you're looking, okay, is it really 5 mm or 6 mm? Whereas if you say is pattern A, really doesn't matter in that respect, is already very low likelihood of lymph node metastasis. It will change their approach.
Great. Thank you very much. I hope you have a good rest of the day, and I hope it remains sunny with beautiful colors outside.
Thank you very much, Richard.
Yeah.
And thank you very much for invitation again. Thank you.
Thank you.
And
Thank you.
thank you very much, Emily, for your
Okay.
Bye-bye.
Emily,
Yes.
I was just going to say to everyone, next week it's back to Hempath, and that's me. And it will be the following week, it'll be interstitial lung disease, by Dr. Leona Joseph, who's a colleague of mine from Manchester. Also, Emily, I don't know if you're able to check with Ava, but next week the clocks in the UK go back. So the time in all the places in Africa will remain the same. So our time of presentation will change from 2 p.m. British Summer Time to 1 p.m. GMT. So I'll be on at 1 p.m. It just looks like my calendar invite is still showing us 2 p.m. I don't know if it's automatically going to change or not. I don't know if
Yeah, we'll make
can
sure
help.
that
Yeah.
that's changed across the calendars and also on our social media platforms as well.
Yeah, but in the countries that don't change their times, which is the majority of countries like Zambia, Kenya, whatever time it was in Zambia and Kenya today, it remains the same time there next week. Yeah. Okay.
Brilliant.
Thank you very
Thanks,
much,
Richard.
everyone, and enjoy your day and afternoon, evening, and night, wherever you are. Thank you.
Thanks, Emil.
Thank
Bye,
you.
guys.
Thanks.
Thank you.
Bye-bye.